The video series Glycemic Control Oral Agents was developed by the Georgia and Oklahoma Academies of Family Physicians as part of the Go Diabetes Initiative. The Glycemic Control Oral Agent series consists of 6 video vignettes, each outlining best practices in the care of diabetic patients. Please proceed to the registration page for more information on the approved number of prescribed credits for this activity as assigned by the American Academy of Family Physicians and AMA PRA Category 1 credit as assigned by the Georgia Academy of Family Physicians. Upon completion of each video vignette, please return to the Resources video page on the Go Diabetes website to complete the activity evaluation and earn your CME. This activity is supported in part by an educational grant from Sanofi Aventis. We thank you for your participation in this online activity and hope that it serves as a valuable educational tool.
All right, now we're going to talk about the medicines. The first class of medicines that's often prescribed is in the class of what's called a biguanide, metformin. Okay, that's the only medication. There is a medicine that was its predecessor. It's called fenformin, that was in Europe many years ago. All the warnings about lactic acidosis that you hear about with metformin are because of problems with fenformin. Okay, the risk of lactic acidosis with metformin seems to be exceedingly rare. Occasionally, you might see somebody that thinks that it was caused by that, but when I did a lot of hospital work where I was previously, and patients that would come in and have lactic acidosis, they're usually septic, hypotensive on numerous vasopressors, and they have lots of reasons to have lactic acidosis besides, and they might be diabetic and be on metformin too, and that's usually not the case. But it's been when metformin was released several years ago, there was a big warning about being careful with that, and it's very, 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 very rare. Its mechanism of action, it shuts down gluconeogenesis, okay? How effective is it at lowering blood sugar? Well, it lowers your A1C between 1 and 2 percentage points. Adverse effects, the most common ones are GI side effects. It can cause diarrhea, it can also cause nausea. I did mention the risk there of lactic acidosis. Despite the GI side effects being what they are, and they happen in about 25% of the people, only about 5% of the people have to stop the medication because of those side effects. They're usually transient. When you're first starting the medication, you want to start slowly and then slowly increase the dose. And you would like to get almost all of your patients who take metformin, you like to get them to about 2 grams a day, okay? That's the dose at which you get the most bang for your buck. There's lots of benefits to it. It doesn't cause weight gain. We're going to talk about other ones in just a second. The maximum dose is actually 2,550 milligrams a day, and that's 850 3 times a day, if you can't remember that. They do make, the nice thing about it is it's $4 a month at a lot of local retail pharmacies. And there is an XR formulation that's generic, and they can take it once a day as well. For those of you who ever read Cochrane database reviews, it can make you feel a bit like a therapeutic nihilist, I think, because it seems like nothing we do really helps. But this was actually a Cochrane review that was given about metformin. I'm just going to read it. And this, for those of you who have read Cochrane reviews, this is kind of a glowing endorsement. But here's what it says, and this was from July of 2005. Metformin may be the first therapeutic option in the diabetes mellitus type 2 with overweight or obesity, as it may prevent some vascular complications and mortality. Metformin produces beneficial changes in glycemia control and moderates weight, lipids, insulinemia, and diastolic blood pressure. Sulfonylureas, alpha-glucosidase inhibitors, TZDs, meglitinides, insulin, and diet fail to show more benefit for glycemic control, body weight, or lipids than metformin. So, for those of you who've ever read Cochrane, you know, hey, man, that's like high praise, you know? This is like for the mean old dad who never would tell his son, good job, you know? That's kind of how Cochrane is sometimes. But when you look at how that's a pretty glowing endorsement for metformin, and that's why it's mentioned as frontline agent for most patients with diabetes. And I'm going to show you some of the studies here that actually led to that glowing endorsement. This is from the UK PDS, And on the left-hand side of the chart on the left, you see any diabetes-related endpoint. And again, these were people treated with both intensive and conventional treatments, but people who were treated with metformin in that study seemed to have a lower incidence of any diabetes-related endpoint, so heart attack, stroke, need for kidney replacement, i.e. dialysis, retinal treatment, happened less frequently in people treated with metformin. Diabetes-related death in obese patients treated with metformin in the UKPDS seemed to be lower in people treated with metformin. And so that's the reason why it does have the endorsement that it does from Cochrane. Okay, any questions about metformin? Key things, we didn't talk about, there's actually a number at which you're supposed to stop it. Women with a creatinine of 1.4 or men with a creatinine of 1.5. I realize that is not the most accurate measure of kidney function in people, but for simplicity's sake, that's the number that's recommended. So if you do have a female or a male with those numbers, then it's recommended you stop that, because that's when you might, and big emphasis on might, see lactic acidosis occur in those people. Okay? So let's move on. The next group we're going to talk about are sulfonylureas, very old medicines, mainstay of treatment for a long time. The advanced study that we talked about this morning, they used glycoside, I can't even say it, glycoside, which is a sulfonylurea we don't have in the United States, as one of their modes of treatment. What do? Well, they make your beta cell, it's kind of like whipping your beta cell. You know, it's like riding a horse and saying, make more insulin, make more insulin, make more insulin. But it does requiring a functioning beta cell, so it doesn't work in type 1 diabetes. They do work quickly, which is nice. So as opposed to like a TZD, which is going to take like a month to start working, these work the first dose you take it, you start getting more insulin output. How effective are they? They lower the A1C between 1 and 2 percentage points. They will lower the fasting glucose about 20%. Main side effects are associated with more insulin. So low blood sugars, weight gain are the main things that are associated with them. You can use them in combination. In fact, there are combination pills that combine sulfonylureas with metformin. Now, as opposed to on the dosing of it, as opposed to metformin, at which you push the dose towards the maximum, up to 2 grams a day, sulfonylureas, you reach the maximum effective dose at about half the maximum dose. Does that make sense? So you don't need to push the dose. If you've got somebody on, think of an example. If you've got somebody that takes 6 milligrams a day of glimepiride, pushing them to 8 milligrams a day, not going to do anything else. Have somebody on glyburide, and they're already on 10 or 15 milligrams a day, trying to bump them up to 20, and they've got an A1C of 9, don't waste your time. You've already hit the maximum bang for your buck when you've gotten about half the max dose on those medications. This is a bit of opinion. I try to separate opinion from things, but these are just sulfonylureas that you can dose once a day that are very inexpensive. They're generic, and that's the reason that they're recommended. Glipizide ER, plain glipizide, and glimepiride are ones. I usually use glimepiride more than anything else, but they're all $4 a month at Target or Walmart, and similarly priced at other retail pharmacies. Okay, this is a slide that shows what happens if you have somebody who is on a sulfonylurea, for example, or somebody who's on metformin, and they come in and they have an A1C of 8. What's the patient want to do? Well, I think I need to change medicines. It's not working. Well, the better option would be to add a therapy as opposed to stopping a therapy and starting another one. And this is the slide that shows, this is an old slide from 1995 that shows what happened. These were patients taking a sulfonylurea in the pink and right here, and they were not meeting glycemic targets. They switched some people and put them on metformin, and not much change, versus some people, they added metformin to the sulfonylurea, and you see what happened. So there was sort of a complementary effect when you took the two together. And that's the key concept there, as opposed to taking either or in somebody. Okay, TZDs. Yes, sir. Among individual sulfonylureas or just as a class as a whole? The best answer I can give you is from the UK PDS trial. If you go back to that slide that showed the reduction, they weren't more beneficial. The only oral hypoglycemic agent that seemed to be, as a class, better than others was metformin. So if you compare like sulfonylureas to a TZD to a DPP-4 inhibitor, I can't tell you that it's going to be better or worse necessarily. I think I would certainly use metformin as opposed to that if I had an option. A lot of people end up being on two of those anyway.